Education and Care Gaps in Tracheostomy Management, a multi-stakeholder survey. That's what I've been talking about in recent weeks. The Education and Care Gaps in Tracheostomy Management, the multi-stakeholder survey, was published on the Global Tracheostomy website, and it's a good survey. It questions a lot of what's happening with tracheostomy care in hospitals and also in the community, but it lacks solutions. And I argue we have all the solutions here at intensivecareathome.com. And I will link to the survey, and I will also link to my previous videos about this survey, because you will see that whilst the survey is bringing out issues around tracheostomy care, we have the solutions that the survey doesn't really offer. So today I want to talk about the access and affordability part of the survey, and let's see what the survey says and what we are doing at Intensive Care at Home. Access and affordability, issues related to access to tracheostomy care for undeserved communities were another significant concern, with 58% of respondents highlighting barriers to care. What is an undeserved community for tracheostomy care? That raises some concerns with me. Is the survey or are the respondents of the survey suggesting there are some people who don't deserve a tracheostomy? On what grounds? We don't discriminate here at Intensive Care at Home. We do not. Just a thought. Geographic factors such as the distance to care facilities and transportation difficulties disproportionately affected rural and low-resource population. Respondents also emphasized systemic inequities in healthcare delivery, including disparities in resource availability and workforce distribution. Affordability challenges rank closely behind access issues. Now, before we go to affordability, I just want to talk about how we solve healthcare delivery, disparities in resource availability and workforce distribution. When we have a client, or when we have clients for Intensive Care at Home, even when we have remote or rural clients, there's always an argument to be made to get a drive-in, drive-out, fly-in, fly-out workforce. That's what we have been doing for many years now. So remote areas are not really an issue. Again, it all comes down to the advocacy and evidence provided. So, the survey here doesn't talk about solutions, whereas I argue we have the solutions. So let's talk about affordability, or what I would say perceived affordability. So affordability challenges rank closely behind access issues, with costs associated with community care, 74%, and prolonged hospital stays, 64%, being the most frequently cited. Of course, we can see that, but that's why exactly one of the reasons why we started Intensive Care at Home is because prolonged hospital stays with tracheostomy or ventilation costs a lot of money, $5,000 to $6,000 per bed day in intensive care. Patients and families, quote unquote, live in ICU and there's no quality of life, right? So that's why we created Intensive Care at Home in the first place, also prolonged hospital stays. We understand all of that, which is why, we created Intensive Care at Home in the first place. To not only cut the cost of the ICU bed by 50%, but also to get patients and families out of ICU, and to make it a win-win, create a free bed in ICU or in hospitals, make it a win-win situation. So then the survey continues. Speech language pathologists and respiratory therapists identified financial burdens as a critical issue. Once again, if you cut the cost of an ICU bed by 50%, you no longer have the financial burden, or at least it's reduced. And also emphasizing the strain on patients and families. Once again, that's why we have started Intensive Care at Home, so that we have an option for patients and families, a much more holistic and patient and family-friendly option for patients and families. Respondents reported inadequate insurance coverage, insufficient funding for community-based services, and high out-of-pocket expenses, further highlighting the need for systemic changes in healthcare financing. Yep, absolutely, I couldn't agree more with that. But I disagree that there's inadequate insurance coverage, because once again, our proposal to insurances, NDIS, whoever it is, we're cutting the cost of an ICU bed by 50%. So why would someone say no to that? Insufficient funding for community-based services, again, that is a perception, not necessarily reality. It all comes down to what offer you are making to insurances, to hospitals, to families. Pretty much all of our patients are not out of pocket, with the advocacy that we are providing, with the evidence that we're providing, our clients, generally speaking, get the funding they need. But I agree that there is more work needed for systemic changes in healthcare financing. I am obviously a strong advocate that more and more funding needs to move into the community, because more and more care and treatment can be provided in the community with the right support structure and not in hospitals. The survey continues. Although respondents were queried separately regarding access to care and financial constraints, these aspects of care are often intertwined, potentially mediated by social determinants of health. For example, economic hardship can limit access to transportation or exacerbate geographic barriers, reducing availability of specialized tracheostomy care. These interconnected challenges highlight the need for addressing both financial and structural factors that impede equitable care. By adopting a more integrated approach to financial and structural interventions, healthcare systems can better address disparities and develop sustainable solutions that facilitate long-term access to quality tracheostomy care. Yep, I couldn't agree more there. These financial and access barriers exacerbate the broader challenges in tracheostomy care. Addressing these financial burdens requires targeted policy changes and systemic interventions. The financial burden associated with tracheostomy care, including costs related to supplies, equipment, and prolonged hospital stays. Once again, we have a solution to prolonged hospital stays. We actually shorten hospital stays. And that mirrors findings from other studies that indicate affordability remains a significant barrier to optimal care. I strongly disagree there that affordability remains a significant barrier to optimal care, because we reduce the cost of an ICU bed by 50%. So I think there's, a level of unknowns for the participants of this survey. They probably haven't heard of intensive care at home. The additional emphasis on inequitable access for undeserved communities reported in our study further supports the call for policy changes to address these disparities and improve resource distribution. Efforts should prioritize addressing the specific needs of undeserved communities with an emphasis on improving access to essential resources and care. I'm very irritated by, not undeserved, underserved, I do apologize, underserved communities. I read it as undeserved, underserved. That makes more sense. Limited access to supplies due to financial constraints represents a fundamental issue that requires urgent policy and systemic interventions. I could not agree more with that statement. Again, that's why we have created intensive care at home, to have a solution to all of this with our critical care nursing workforce in the community. So with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: home care services for ventilated adults and children with tracheostomies with critical care nurses 24 hours a day. A genuine alternative to a long-term stay in intensive care or long-term acute care. We're providing tracheostomy care, home care services for patients on non-invasive ventilation, such as home BiPAP, home CPAP. We're providing services for home TPN, also known as total parenteral nutrition, which is also known as IV nutrition. Also, home IV potassium and home IV magnesium infusions, IV fluids and IV antibiotics. We're providing central line management, PICC line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube and PEG tube management at home, cough assist machines for our clients for airway clearance at home, palliative care services at home, as well as ventilator weaning at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day. And we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. Of course, quality of life is much improved surrounded by families instead of staying in an intensive care unit. With intensive care at home, we're currently operating all around Australia in all major capital cities as well as in all regional and rural areas. We are an NDIS-approved service provider all around Australia, TAC and WorkSafe in Victoria, DVA, Department of Veteran Affairs, all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are currently the only service provider in Australia that has achieved third-party accreditation for intensive care home nursing in 2025. We have been achieving this level of accreditation since 2012. No other provider in Australia has created more intellectual property when it comes to intensive care home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. If you are at home already and you're watching this, or you're stuck in an ICU, or if you're going to hospital and ED all the time and you realize that you don't have the right level of support at home, or if you're living in an ICU, I'll give you a very tangible and real-world example today. One of our first clients, when we first got started in 2012, was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, support workers are not equipped to look after a ventilated and tracheostomy client. That is dangerous and it's negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at risk of dying if they don't have a team of critical care nurses looking after them 24/7 at home. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecareathome.com. Think about it, in an intensive care unit in a hospital, you wouldn't have support workers looking after your critically ill loved one or after any critically ill patient on a ventilator with a tracheostomy. So why would anyone in their right mind would do that in a home care environment in the community? So this client found out about us eventually, and the ICU that he went back to all the time also knew about us and eventually reached out to us, and we were proving our concept with this client very fast. When we worked with this particular client, we sent him intensive care nurses 24 hours a day, and he never ever went back into ICU ever again, as long as we were working with this client. We can do the same for you if you're not safe at home, and help you with keeping you at home predictably. Otherwise, we wouldn't be in business. The same is applicable for those stuck in an ICU, similar to this case study that I've given you. Or if you're going back to ED all the time, please reach out to us. We can help you with taking you through the right steps, including how to get funding with different funding bodies. This is also why we are providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Richards, one of our NDI support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management in Victoria. If you're an NDI support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. And if you need more evidence for nursing care, we're also writing nursing assessment, NDIS nursing assessments with legal nurse, critical care consulting nurses. And if you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined, and you can join this high-performing team. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again because they are so vulnerable and so special, and that's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building solid relationships with us and with our clients. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. If you are a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, or home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US or in the UK, and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecarehome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecarehome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecarehome.com, and I will talk to you in a few days. Take care for now.